Hello everyone, my name is Ignasi de la Rosa. First of all, I'm going to introducing myself. My education background is physiotherapist, and also I have a degree in sports science, but then I developed more in a master in sport performance and rehab and in integrative physiology. My background is all my life very related with sport. So I was first of all a triathlete, and then I start working with endurance sport people and also with tennis players and football players. So my highlights in tennis, it was with Garbiñe Muguruza, who reached #1 in the world, 2 majors, Grand Slams. And also in football, that is where I'm working right now. I start with Mike Bartra since he was in Football Club Barcelona. Then I traveled with him to Borussia Dortmund, and now we are in Sevilla together. So let's go to start with the concept part. So as you know, Tecar therapy, it means electrical transfers with 2 different modalities, the capacitive mode and the resistive mode. What the most important thing is to understand that it's a monopolar current that depends from the frequency. So what we know from the studies is that we have a sweet point between 300 megahertz and 1.2 megahertz that induces and increases the intra and extra cell exchanges and has a diathermic effect on the living tissues. This is really important, on living tissues, not dead tissues. So if we go more in deep in the permeabilization principle, what we have is an electrical current, alternated electrical current, that what it's gonna generate is an oscillations of ions, of potassium ions. If we remember our basic formations, we know that we have different sodium, potassiums that we need to sell ATP, okay, to mobilize the sodium ion, and then the potassium is gonna move for gradient. So if we can polarize this membrane cell, what we will provoke is to concentrate more potassium in one side of the cell, and then this is what is gonna generate to increase the metabolism of the cell. So if we follow to this, to understand how this electrical current is gonna work, it will depend from 2 different things, that we need this sweet point between the frequency that I just said before. It's the conductivity and the permittivity. Permittivity is an electrical concept, but it's in biological tissues, it's gonna be the permeability of the tissue, how easy the electrical current goes through the tissues, and the conductivity is gonna depend of the resistance, the impedance of the tissue. So hard tissues with less density of water is going to generate more impedance, and tissues with more density of water, like muscles, for example, it's going to generate less impedance, okay? So then with the Winback machine, we can work at different frequencies. We have the 300 frequency, the 500, and the 1000. So as less frequency, we can go deeper to the tissue because the wave that we are working, it's less concentrated. And at higher frequencies, we will keep more in the surface because we have a more concentrated wave. What this means is that in biological effects, we can go until 5 to 7 centimeters with the deep frequency, but we need more time to have this biological process, okay, to mobilize more ions and to accelerate the metabolism of the different tissues. So in the other part, in contrast, we also have a thermal effect that it comes from the own law principle. So that means that tissues with more impedance that generate more resistance will get temperature before. So with this, we can create the diatherm effects, and with different diatherm effects, we can improve, or we can make different stimulus to the tissue. We have from athermia, or very low thermia, that it's in blue in the screen, until hyperthermia, that you can see it in red in the screen, okay? Then next one is to explain these two different modalities. Okay, so with the capacitive modality that comes covered with an impedance material that is a polyamide right now, we will generate or we will concentrate all the thermal effect very close to the mobile electrode. And the mobile red electrode comes without any isolating material. So it's really metal, it's a metal thing, okay? So that means that the most hard tissues in the body will generate this resistance to the current. So these hard tissues will take the energy before, and then for the saturation process, we can work in thermal effects all the tissue. But we need to have in mind all the time that we are working in two different ways to the tissue. First of all is the biological effect. That depends from the frequency. At less frequency, we will go deeper, and more frequency, we will keep on the surface. And then the thermal effect. For example, if we are working on a tissue that is with an inflammatory process, we will work at low temperature or athermia. And if we are working, for example, in a chronic process, for sure, we will need to work at hyperthermia or in some points at hyperthermia. One of the other things that I want to explain you in this introduction is the contraindications. So we are generating electrical current through the body. So pacemaker, insulin pumps, it's forbidden. Thrombophlebitis is, for example, if we are working at high temperatures, could be a serious problem. Pregnancy, we cannot do scientific studies with pregnancy women, so we don't know how can affect this to the fetus. In low cartilage, also for the temperature. Of course, if somebody have problems in the sensitivity of the temperatures, cancer, because also we can develop when we are accelerating the metabolism of the cells. And then, of course, if we have a suspect of a fever or an infection, we will not work with a technology that is going to increase the metabolism of the cell. So next one is going to show you how the red energy that it's going to cover all the tissue that we are working between the mobile electrode and the return plate, it's going to work. So you can see different photos with a thermal video that we can work on the different joints, like the elbow, for example, here and different positions, okay, or also in the knee if we have the guy lying down. So now I'm going to show you some videos how it's going to work the machine. And to understand these videos, I need to really quick to explain you the installation of the machine. So what we need first of all is to put the return plate and the mobile electrode in contact with the patient, okay, with the cream, that it's a conductive cream. And then let's go to program the machine with the capacitive of the resistive mode. Most of the times we start with the capacitive because that is going to allow us to increase the temperature in the first centimeters or of the tissue. And then we can go deep with the resistive modality through the treatment. What is really, really important to understand is that this technology is generated, or it's thinking all the way to integrate with our manual therapy like a physiotherapist. So I mean, it's not I'm going to treat the patient with manual therapy, or I want to treat the patient with the Winback machine. Best results is when we combine the technology, when we integrate the technology, and we have the power with Winback therapy to make our treatment more easy and more efficient, of course. Okay, so let's go to show you, first of all, the modality more easy, that we have the return plate and we will start to work with the machine. You can see that we can integrate our manual therapy in different treatments. For example, here we are working on a shoulder, okay? I will not show me, it's going to show you a lot of or some videos about this, okay? But this to show all of you how we can work with the machine and how also we can integrate our manual therapy or different mobilizations with the help of the technology, and it's gonna help us to increase the velocity of the recuperation and the rehab for sure. Okay, so here you have some examples. Then if we go to the things that we can do also is to work through our body. This is called MyVac. So this means that we put the resist modality, the resistive electrode in contact with our body, and then we can go directly with our hands, and the energy is going to go through our body to the patient. Okay, you can see here, for example, how we can treat different parts. If, for example, if we have a spot or tear point that we want to work with more energy in that spot, this is one of the really good solutions and really good integration that we can combine our manual therapy with the Winback technology. Okay, then, for example, let's go to see how we can do with the dual mode, with two hands working with two mobile electrodes. One is going to work with a return plate and one is going to work like a mobile electrode. But now is the patient who is going to make movements, or, for example, we can work also with a passive patient, but we can do the mobilization, concentrating all the energy in the spot that we want to recover. So here, as you can see, I just start to work on the shoulder of this woman. And now I ask to her to move the shoulder in different positions. Now I'm working with different mobilizations, and now the woman is not doing anything, it's a passive movement, but it's also to show you how we can integrate the technology in different lines. So now I want to present you the multipolar mode. The difference Okay, so I prefer to explain you. In that case, the difference is that we have in the same mobile electrode the resistive part and the return plate. So that means that we choose the program in the machine, and then we can go through the body with the mobile electrode in the same spot. One of the benefits is that really easy, because we don't need to think where we put the return plate or where we are going to put the mobile electrode. Okay, to put the tissue that we want to treat in the middle. In that case, we can go through because everything is integrated in the same electrode. This is gonna really to be really useful when we are working on soft tissues, tendon surface, okay, and also in scars, okay. But for example, if we want to work on deep tissues, it's gonna be better if we keep the monopolar mode with the mobile electrode and the return plate, because the energy is gonna go through all the time the body and cover all the tissue that we have between the mobile electrode and the return plate. So all of the time when we are doing the installation of the machine, it's really important to keep very close the mobile electrode plus the return plate and put in the middle all the part that we want to treat, okay? And now I want to show you also the next accessory that it's called Tecar 6.0. Then let me one moment, you will see it now, because this one have it's coming. Okay, and now listen please one moment. one of the new accessories that we have in Winback is the Tecar, that this accessory gives us the possibility to concentrate all the energy in small spots that we have in this accessory. You can see it here. And then, for example, imagine that we are treating this Achilles tendon that is in a degenerative process, so we need to put a peak of intensity to get a lot of temperature, more than 40 degrees, to stimulate the collagen synthesis. So in that case, what we are going to do is to work on the Achilles tendon, press this button to close the circuit and start, and after some seconds, she's gonna tell us, okay, be careful, it's too much, stop for 5-10 seconds, and we will start with the treatment in another spot. So after 5, 6, 7, 10 seconds maybe, she's gonna tell us again, stop. So we will give her 10 seconds of rest, and then we will go again to another spot. In this Achilles tendon, we will start first with the capacitive modality, then we go through the resistive plus all the exercises that we did in the gym, or for example, if we put the bracelets, all the stuff that we did in the soleus and the gastrocnemius, from the fascia and from the muscles, and then we can finish this treatment with the Tecar 6.0 to give to this tissue this peak of temperature, this point of temperature, to get these new adaptations. Okay guys, so it's really important to understand this part that I explained in the Achilles tendon, that we will have a process in the treatment. So remind all the time that Winback therapy and Winback machines, what is going to allow us is to combine our techniques. For example, sometimes also to prepare the tissue, that then the tissue is going to be more ready to accept the treatment, okay? And sometimes we can do it, for example, in the final part of the treatment, to send a peak of energy that I just explained you in that video, to have the possibility, okay, to generate some stimulus on the collagen synthesis. And then finally, okay, I want to show you also how we can combine the Winback therapy with some examples with active rehab. So as you can see, I just mix all the exercises that we can do in a phase 2 or phase 3 in a process of rehab, okay, with or plus the Tecar energy. So the benefits are for sure. We are doing some proprioceptive exercise, some strength exercise with easy inertial machines, and we can combine stability exercise with strength exercise, with mobility exercise, and also, of course, with all the accessories that we have, we can combine our manual therapy plus the benefits of the technology. So that's all for me. I hope that it's going to be interesting for you. So I'm now stop my sharing, and I hope that Ken is gonna follow the all yours, Ken.
Thanks. I need to be able to share my screen. Oh, there we go.
Yeah, you're ready, Ken. Thank you, Ignasi. And now I think you can share. If not, let me know.
Yep, I'm good. All right. Do you see a PowerPoint slide?
Yeah.
Yes.
Perfect.
Okay, great. Always a challenge when working off dual screens to figure this stuff out. So thank you.
A new life.
Let me just move my view here. Great. Welcome. Thanks again for having me. My name is Ken Johnson. I'm the Director of Outpatient Rehabilitation Therapy Services for Johns Hopkins Hospital. I have been here for about 10 years and have the privilege of working with a tremendous team of therapists that challenge me, push me, and physicians and patients that expect and demand nothing but the best in terms of the talent, technique, and technology that we provide them. So as we start off, make sure I'm on the right screen. So as we start off, I have no relevant disclosures to provide you. There's been no compensation for my time here today. I do this out of my interest and desire to share sort of the innovative ideas that our team has come up with, and to highlight new and emerging technologies that can help benefit patients, and also to share with you just the way that we've tried to piece together a number of different technologies and give you a bigger perspective, similar to as Ignasi did just recently. I also just want to make sure that there are some videos in here that you will see, and necessary permissions have been obtained from people to display those. Our outpatient therapy services here are comprised of physical occupational speech therapy. We also do work with physiatrists and rehab psychologists as well. We've got a number of locations around the Baltimore, Washington area. For those of you that are here in the US, our geography. And for those that are joining internationally, I welcome you as well. We have just recently opened a couple musculoskeletal centers. These are interdisciplinary facilities that include ambulatory surgery, musculoskeletal physicians, orthopedics, physiatrists, imaging, and therapies. We also have some innovative applications in embedding a clinic within a performing arts facility, and music and dance conservatory, as well as a number of multi-specialty provider clinics in and around the area. Our facilities, as I mentioned before, we do try to investigate and explore some of the more advanced and innovative technologies that we can to help provide our patients with the very best and very latest. And a lot of what we have incorporated has been things that we found at conferences and travel in and around the world. Excited to have a partner in France. So that's kind of a new one for us, as we do have a number of other European technologies. So with that, really at the center of this discussion really is our goal as physical therapists to help optimize human movement. And we do that in a number of different ways. We do it both actively and passively. We do it manually, and we do it with technology. But again, our primary driving force is to try to improve our overall human experience. Osteoarthritis and musculoskeletal conditions are certainly something that has a high prevalence throughout society, regardless of your geography. The bias is that there are a very large number of people that their disease progression or their condition may be mild in limitation, but mild can also be relative. If you have an arthritic knee and you happen to play professional sports, which oftentimes does happen, trying to find a way to maintain your livelihood and keep on the field and keep performing is certainly a paramount concern. Whereas the average person like me that is not making a living in sports, that osteochondral defect that may prevent me from running pain-free, is not as big a deal. So, you know, a lot of our consultation, my consultation can be with athletes from the NFL, Major League Baseball, our US and other international Olympic groups. And while those are very high performers, they obviously don't comprise our everyday average population that we see in the clinic. But it highlights some of the challenges and the concerns that a wide variety of people face. You know, as we look forward to the future, you know, we see that, you know, our population is only getting older and aging, and age-related disease or pathology is going to continue to increase in its prevalence, making all the more important our profession and what we do to care for and help people function at the highest level possible for as long as possible. We do know that there's a high link to decreases in mobility and the progression of disease as we get older, not just with osteoarthritis, but heart disease and other cardiovascular disorders. So, you know, movement is an important thing. You know, musculoskeletal is not as on the acuity or alarm rates as maybe cancer, diabetes, you know, other stroke, very severe, obviously, conditions. But musculoskeletal disorders are something that can sneak up on you over time. So as we seek to try to maintain this envelope of function, you know, we look at how activities influence the loads on the body, the stress that it faces, and how it can lead to structural failure. Certainly there are, you know, very traumatic things that we can do. You know, jumping from a 3-meter height is going to significantly load our tissue and cause pretty significant traumatic stress. Whereas walking for 10 kilometers is probably not going to be as debilitating or devastating on our joints. So trying to find ways in which we can influence or modify that envelope of function that allows people to do whatever it is they need to do is critical. You know, as we move into this talk, this multimodal approach, you know, we have to look at how structure and function interplay. And, you know, with normal gait, we expect to have, you know, good, solid frontal plane stability. So strength within our hips, our gluteus muscles. When we lose that, we develop compensatory patterns, and they can come in a number of different shapes and forms. Those compensatory patterns can lead to abnormal stresses, whether it's on the medial compartment of the knee, or it could be a hip or bursitis irritation more proximally. But as we develop these compensated and uncompensated gait patterns, it leads to pain, dysfunction, and a referral for hopefully therapy. So, you know, to address that, we've been sort of refining this model over the last 10 years or so, trying to find, you know, again, that sweet spot that Ignasi talked about earlier in somebody's care. And so I want to talk about a model and propose it to you. It's certainly something that is constantly evolving, but I wanted to talk about the role that Tecar played in that model, as well as some of the other technologies that we have. Obviously, we're talking about multimodal approach and looking for innovative ways, not just to treat a patient, but also to engage them. If I give somebody just the same basic routine that they could go find online or on Instagram, you know, they're not going to travel hours either by car or sometimes by plane to come see us. And sometimes we have the privilege of getting flown by, you know, plane to go see people. And a lot of that is because, you know, we seek to offer a unique solution and a unique experience to help them manage their pain. So this model that we are here to talk about, you know, as I mentioned, kind of bookend it. You know, Tecar's role, and I'll speak, you know, more directly to how I have integrated it. You know, I'm always grateful to listen and learn from other advanced clinicians, whether it's Ignasi or Fred who've integrated it, even far and beyond, my abilities. So I respect its role, both as the preliminary phase to a treatment, as well as how it fits into a movement-based model as well. So, we start by warming and preparing the tissue using the forms of the capacitive and resistive elements of the technology. It's a far more advanced way of deep heating the tissue. The studies looking at how much heat actually penetrates from a hot pack, and we don't use a whole lot of hot packs anymore, because we can heat the tissue really from within. And this was a really intriguing concept that was shared with me by a friend from Scotland, Mr. Paul Donnelly, a few years ago. I'd heard about Tecar for a number of years. I'd seen it on Instagram. I've had some friends and colleagues that had played around with it, but I could never honestly quite get my head around all of the stuff that Ignasi just talked about. For me, it was really feeling it. And it took somebody driving 3 hours or more from, I was speaking in England, and a friend who was with English cricket, made the connection and drove 3 hours to let me feel it. And that's when I was kind of instantly hooked. So, from that, it was figuring out, how did it fit into this model that I had already created for myself? Looking at how mechanotherapy, whether it be through instrument-assisted soft tissue mobilization or, shockwave, or something that very prevalent and common in my practice, how did it fit in with those types of treatments? The decongestive therapies such as negative pressure therapy or cupping is probably a bit more commonly known, is the decongested method. Where does this tool fit in with that? And, but ultimately, how does it lead to helping patients get back to movement? So I'm going to walk you through this little journey of what I call more evidence-informed, because as you'll see, in terms of Tecar therapy, is relatively, new, and, there's not a huge or overwhelming amount of meta-analysis being done to highlight, its effectiveness. So, some of the modeling that's out there, whether it's, looking at how Tecar has been shown to improve pain and function, the self-reported types of function with WOMAC, or how it can help to improve fluid exchange or lymphatic flow. There's some very interesting, studies that are starting to come out, and even looking at how on the more on the surface, how can we influence blood flow into an area through the tissue temperature elevation and heating, both deep as well as superficial, has been shown against sham and other placebos to have some interesting merit. But we do concede that, as with anything that's sort of on the new or leading edge, that there's always room for more opportunity to research and study that, which is great. If you live your life in a lab and, you need to pioneer and innovate. The studies that are published today are oftentimes published. Evidence is the first building block to building a research agenda. So I acknowledge that and keep that center as part of my talk here. But at the end of the day, when I've got an athlete that travels 2 hours or more by train to come get care, they don't necessarily care about the research or the science. They hope that my experience and my clinical decision-making is going to help get them back on the field. I shared this video here as this is, I know, a little bit detour from the osteoarthritis talk, but Division I soccer player, football for those of you in the UK and abroad, that had for 3 years had debilitating Achilles tendinopathy, and had received care from stem cell injections and, you name it, everything had been done. And this was in her, one of her first times back on the field after missing nearly 3 seasons. Tecar did an amazing job. It was the difference maker in the care of this problem. We worked on some mechanical things as well, but again, when your son or daughter makes the game-winning goal in a very heated playoff run, again, nobody cares about what papers have been published on the applications of something. So that's that. So, moving back into the talk, some of the ways in which, we will progress through and I start with the capacitive, warming of the tissue, getting the microcirculation brought into the area to help prepare for sort of the next phase. And, one of the other things that I really liked about, the resistive type of Tecar, with the wristlet is that, that really allowed me to continue to keep my hands on a patient. I can feel for those subtle changes or nuances in the tissue, in the tendon, in the joint line, and I could really target and focus, concentrate that heat and energy right where I needed it to be. And then, of course, the multipolar is great for that very superficial, all-in-one, targeted tissue care as well. So, preparing the tissue, warming it, getting it ready, decreasing pain, increasing tissue oxygenation, following it with some of our standard practice mechanotransduction using, shock waves or Huck Grips tools to allow us to mobilize the soft tissue to relieve stress of the retinaculum and other fascial barriers that may be there to limit or inhibit someone's free-flowing movement. So, working in from mechanotransduction, we have also then sort of to make the decision as we start to unweight or unload somebody, how are we going to go about that? Can we use, one of our anti-gravity treadmills that's an air-based technology to unweight someone and get them moving comfortably without the stress, or perhaps it's going into an aquatic environment where the use of water has long been shown to help us manage an arthritic patient. Whether it's decreasing pain, improving self-efficacy through actually being able to exercise again. I mean, the patient I have coming right after this lecture is traveling an hour to come see us because of the benefits that he feels being able to exercise again when loaded full gravity exercise has been problematic. So again, thinking of our fluid dynamics and how activating and exercising muscles in a warm water environment, we've heated the tissue with the radio frequency stim and Tecar, and now that allows us to start to reintegrate movement patterns and resistive training, but in a nice, warm, protected environment. As we look at decongestive types of therapy, we've sort of compressed it, we've loaded it, we're using hydrostatic pressures to try to facilitate pumps of moving that lymphedema and fluid that can occur from arthritis and arthritic related pain. There's a variety of studies on cupping. Again, it's one of those things where, being cautious of the literature that you're consuming is a challenge. There's a number of studies that do show that, cupping can provide, or negative pressure can provide some limited evidence, either in, reducing pain or improving function in a narrow way, or improving range of motion. But, it's oftentimes combined with a more a more multimodal approach, whether it be exercise or other, to help achieve the desired outcomes. So with that being said, again, evidence informed, but we're mindful of the different ways that we can use cupping and negative pressures, whether it be through static, dynamic, functional cupping. There's a lot of different ways that we will link that in with the care of our arthritic patient. Whether it's putting static cupping on a limb and working dynamically underneath it to relieve some of that fascial stress, or perhaps it's using a technology that helps provide a more graded or medically controlled negative pressure environment to help move fluid, help relieve tissue stress, and help improve somebody moving. As we get to improving movement, and now we need to start to address the strength. We identified strength as a component of the biomechanical forces that can lead to osteoarthritic and knee pain. And using eccentric loading, computer controlled eccentrics, and biofeedback is a great way for us to physiologically load the tissue and to help get its strength back. But it also allows us to control the loading, as well as improving balance and muscle activation in those areas. Waking things up is an important part of what we do. And while we may not apply it, and as I said, I'm always learning from Ignasi, and some of the things that we could now possibly do by incorporating some superimposition of Tecar with these types of movements could potentially further enhance their outcomes. We stay with a fairly simple exercise program that we send people home with. It starts with a simple unweighted neuromuscular reeducation. We progress through a series of isometric double and single limbs activities into double dynamic and dynamic single limb activities. I'm happy to share sort of this more evidence-based approach to what we do, and finishing out with sort of our more single limb ballistic activities. And those are the things that are more encompassing our higher level athletes and participants. But when we say evidence informed, again, how we structure our exercise programs, we look at the EMG patterns and what muscles are most active with the exercises that we select. So our programs have a high concentration of the clamshell, in order to get and side-lying abduction to help get the upper fibers of glute max. But then working on some of the lower fibers, we're using the hip lifts and isolation there. But each one of these elements is factored into the exercise program that we do. I'll skip over that. That's a duplicate slide. So our exercise prescription is oftentimes focused on isometric holds, building that neuromuscular control, 3 to 5 minutes of work, so it's a high volume reps to fatigue. And our progression through that model is based off of their successful completion of the homework that they've been assigned. We tend to be very criterion based in terms of our functional progressions, and would think you would be the same. Some of the things that we can add in and that we incorporate into to help augment or enhance the strength benefit, particularly as many of the arthritic patients that we see, we incorporate in blood flow restriction technology, and that can come in a number of different ways. There's a lot of different systems that are on the market, all very effective in different forms, and it's important to be an informed consumer there. But the overall concept of blood flow restriction, is showing that as we age, we have reductions in muscle mass that occur starting at the age of 30. As we age, whether it be through decrease in mobility, but we have increases in fall risk and higher mortality rates in those who are not strong. and so this is another area where we're exploring ways that we can innovate and provide sort of new strategies for how our patients can get better. You know, when we think of our traditional strengthening paradigms, we're looking at 60 to 80% of maximum voluntary isometric contraction. What the blood flow restriction allows us to do is to work at much lower loads, much lower settings. Again, this can be done independently or in conjunction with your Tecar as well. But working with lower loads allows us to go with higher repetitions. Higher repetitions also helps with improved motor control. You know, the whole idea of blood flow restriction is really to achieve muscle hypertrophy. But in order to do that, we have to provide a physiologic stress. Physiologic stress, as you know, when somebody who has an arthritic joint, is very difficult because of the compressive loads that you're going to find with the patella in the patellofemoral joint or in the trochlear groove itself. So in order to disturb homeostasis, we can disturb it in a number of different ways. You know, obviously we can disturb it with a radio frequency. We can disturb homeostasis by using an aquatic environment or a resistant environment. But we focus on, you know, sort of the three main, you know, metabolic crisis or the consequences that they have. And, you know, early motor units are going to fatigue and stimulate local protein synthesis within those working fibers. That's going to convert over into the use of more fast twitch muscle fibers, which is going to lead to, you know, a greater movement pattern and a greater activation over the long term. You know, simple programs that we will use, you know, take within anywhere from 20 to 40 minutes and are super simple. We look at full body work because full body work is, you know, necessary to create a more systemic metabolic crisis, and that systemic metabolic crisis is going to help us not just in the knee, but in the hip, in the core, in our upper body, as upper body is just as important part of gait as our lower. So, you know, these are all just sort of the different ways that we can flow through sort of that innovative model for addressing arthritic knee pain. But, you know, as we said from the outset, you know, it has to start somewhere, and I've been really pleased with the response that people have, patients have had with the introduction of a nice gentle warming to prepare them for movement. It's been a nice adjunct to the care that we provide. So I'd encourage you to, you know, to always consider, you know, movement-based strategies as your end goal for your therapy plan. You know, exercise is important, but you know, you've got to warm them and get them ready to go before you start doing all the heavy work. You know, work within their envelope of function. You know, you can modify that envelope of function by using different environments or mediums within which they're exercising, whether it's loaded or unloaded. You know, we like to take a passive approach at first because that builds trust and confidence. Making somebody feel better is going to make them a lot more adherent to sticking with therapy, and managing their pain is essential. You know, we like to encourage people, any type of lower extremity involvement is engage the hip. You know, look at the hip and see what's going on up top, because that's going to control the rest of the limb in space and when that foot meets the ground. You know, consider the role of technology and what it can do to help augment the care that you provide, and you know, be open and explore, feel it, try it, demo it. You know, patients are the best. You know, patients are the best. You know, they're not going to keep coming back to you if what you're doing for them isn't helping. You know, people are going to come from farther and farther away when they find that you have a new solution or an innovative way to care for their problem. You know, the words that I love to hear the most in our clinics is, nobody has ever done that before. I've never seen that before. You know, that's what I live for. And that's what we strive for here at Johns Hopkins. And lastly, consider the role that blood flow restriction training can have in any movement-based program that you're providing. Especially for those of you that are rehab professionals, this is not just for the strength and conditioning community, but it certainly is something that applies very well to the rehab community as well. And be creative. I still have a lot to learn about ways that I can integrate all of these tools and technologies and techniques. And that's part of the journey that we're all on is together, is taking the time to listen and learn from one another. And I thank you for joining me and putting up with me talking really fast in order to stay within my time limits. Feel free to reach out and ask questions. As I said at the outset, I have no financial relationship to disclose with Winback. We're a customer of theirs, very grateful of the solution that they've offered us. And they've been a part of our future growth strategy as well, as we work on integrating them throughout all of our locations. It's a final story on this. We recently just completed our very first pelvic health residency in physical therapy. And one of the conditions of hiring was that the therapist that was staying aboard, who's going to be going to a new clinic, was wanting to ensure that she was going to have access to a Tecar therapy at her new location. And so I need to talk to you, Matt, when we're done. But yeah, that's the impact that it has. It's not just for osteoarthritic knees. We've got therapists using it, for pelvic health, for upper limb, for hand. It's really been a great adjunct to the care that we offer here. So thank you for inviting me, and thank you for listening, Fred, and Ignasi. Thank you for the time that you spent in training me and over the years and helping our team get up to speed. Thank you.
Thank you, Ken, very much. Just a phenomenal, presentation, and it was truly an honor for us to, to be able to listen to this amazing talk. So we've had a lot of, some questions on the chat, and one that I'm going to read to you coming from the UK. So can you objectively put a number on the differences you've seen since incorporating Winback versus before you had it in your practice?
That's a good question. I am probably not the most scientific person in the room to speak. I tend to gravitate towards what I feel is working and the feedback that I get from patients. Does this work 100% of the time? Does everybody absolutely love it? Yeah, no, it's kind of like anything. I think the good clinician is going to have a lot of tools in their toolbox, and I still am learning, pattern recognitions and trying to identify, what tools am I going to use in this situation and what works best. And, I do find that when somebody has deep pain, bone pain, joint pain, insertional tendinopathies, I find that they do respond and react, very well to this. The tendinopathies in particular, I think work well because of the low water content in that tissue and the heating that comes from the friction and the resistance of the electrical, passage through that space. Again, I go back to judging it by the distance that people will travel. They will travel and drive by hundreds of clinics to come to us. And, I'm a nice guy. I try to be nice and all that. But at the end of the day, people are going to go to who's helping them the most. So, I'd say that, you could judge it by me being a skeptic on this several years ago and until I felt it. And, then, now we're looking at our third unit. And yeah, so I guess, as a clinician and as a decision maker, we're deciding with what works by, it's not just me. I saw the question from August that, really for pelvic health, Absolutely. I mean, there's studies out there, you know, with it helping erectile dysfunction and Peyronie's disease. You know, it's a blood flow device, and it's helping people improve blood flow. It's an adjunct to other, you know, I'm not a pelvic health therapist, so I don't want to overstep my territory, but, you know, I would say look forward to the future when you know, Matt and his team put together a pelvic health lecture. I've been amazed by the response by our pelvic health therapy team, because it gets deep, and actually the therapist is on the talk. So Teasley, you know, is really just done an amazing job with with Tecar. So I would defer to her and look forward to hearing a talk from her. I think that was a very long-winded answer.
Very good answer.
I can't put an objective number. Is there other questions?
Yeah, I was going to ask Frederic, Ignasi, Mark, do you have any additional questions?
Well, in name of thank you very much for, well, first of all, Mr. Ken Johnson, it was amazing experience to view your presentation. So it's always good to learn, and everyone learns. So it's great, and also Ignasi for also your presentation and everyone. And so for me, it's been even I'm many years with Tecar and with a lot of professionals. It's been an honor for me today.
I only want to say thank you to Ken for his presentation, and I also want to add that there are a lot of scientific studies that also show us that for the increase of temperature, we can, for example, increase the biochemical parameters of athletes, for example. So in different ways of thinking, if we investigate more in Tecar technology, for sure, we will discover a lot of different applications more.
Experience breeds evidence, and I think the more people that can get to start using it, to incorporate it, you know, again, there's a lot of people out there far smarter than I am, you know, and I look forward to reading. I'm sure some of them are on this talk. I know one of them is, Teasley, but you know, I look forward to seeing great things come from the future of people integrating this into their practice and exploring what it can do to help patients get better.
Amazing, Ken.
Amazing, guys. Thank you so much, Ken. Thanks, Ignasi. Thanks, everybody. So we're going to close the webinar at this point. For more information, as I said earlier, the webinar will be available on our website, www.winback.us. So please let us know if you have any questions. Thank you again for your attention today, and have a great day and a great weekend.
Thank you to everyone.
Thank you, everyone.